Thank you, Rich. Once again, for a difficult question like that, my answer is very simple. In my practice, the answer is yes. Uh, so I'm just going to give you a kind of an overview about various surgical approaches to orbital lesions. This is a 3-day talk crammed into 8.5 minutes. I'll try to do the best that I can. So when you look at orbital pathology, whether you're a pediatric ophthalmologist, a general ophthalmologist, or an oculoplastic surgeon, simplest classification is the way we look at, as surgeons look at it, is either from a geographical point of view, where in the map, the orbital map is the lesion, the location of the lesion. Is it a primary pure orbital lesion, which is the vast majority we manage, or is it one of those challenging cranio-orbital lesions or sino-orbital lesions? That's where multidisciplinary approaches come in. And the other thing we are looking at is, the presenting case of chloromas. What is my approach to it? Am I going to do an excisional biopsy, incisional biopsy, needle biopsy, and so on and so forth? So that's where mentally forming a differential diagnosis as a benign, pre-malignant, or malignant condition is very important. And important to realize that the orbit stays right smack in the middle of the midface, which is surrounded by the sinuses on all four sides. We talked about that before, the brain behind, and the temporal fossa on the outside, which is where it's exposed to trauma. So there are conditions where we don't need a tissue diagnosis. It's a clinical diagnosis. Thyroid eye disease is a classic example of it. Orbital cellulitis, not preseptal cellulitis, is a classic example of where you look at the patient, if imaging is available, you look at the imaging and go ahead and manage the patients. But more frequently, you want tissue diagnosis. That's where you're deciding between incisional biopsy, as in a case of lymphoproliferative disorders, or you're doing an excisional biopsy, removing the entire thing in toto, or are you going to do a more radical procedure as an exentration, and every once in a while, just sticking a needle in. Even the case of an orbital hematoma that somebody presented earlier on would have been a great case for a needle aspiration of the lesion. You want to look at it topographically in a three-dimensional aspect, and we classify lesions on the superior orbit, inferior orbit, and whether they're predominantly supromedial or supralateral orbit, because certain lesions are predisposed to certain locations as well. And like I told before, the medial compartment is the most difficult compartment, partly because it's very vascular, and partly because the axis is very tight. Does it work? Yeah, okay, so I think I'll carry on, thank you. So when you talk about incisions, how are you going to approach it? Once again, we talked about conjunctival incisions and cutaneous lesions. Historically, the gold standard neurosurgical way of getting to the orbit is through a coronal approach. Thankfully, we don't do that anymore, unless it's a combined cranio-orbital lesion. Vast majority of orbital approaches are through the eyelid creases, through the subbrows, which I don't do much anymore, usually combined with the lateral canthotomy with the various canthalyses, either inferior canthalysis, superior canthalysis. The other way of going about it is mucosally, and that's where conjunctival approaches are becoming more and more popular, provided you have a good grasp of what the pathology is and which anatomical quadrant the lesion is in. So a lot of the inferior orbital tumors, well circumscribed tumors, like this patient who's got an incidentaloma, a CT scan for something else detects a lesion right there. It is not a humongous, larger than the size of an eyeball, where a simple swinging eyelid approach, inferior transconjunctival approach without an osteotomy is enough to take out these lesions, and the patients recover very well. This is a lady who presented with a superior orbital mass, and on the feel of it, you can say it's just tip of the iceberg that you feel. A simple lid crease approach under local anesthesia is all that is necessary to remove that 3-centimeter linear cyst that was present along the superior orbit, all along up to the apex, all under local anesthesia from a frontal nerve block. An example of a patient who, again, you can see the dystopia of the globe itself, and you realize the globe is pushed down and in, and he's got a nice lid crease. And the lid crease is now good enough because we know this is a benign condition, because you can see the remodeling of the bone, not erosion of the bone. You're able to get to the entire subperiosteal space, the conal side of it, go to the back of the orbit, and based on the differential diagnosis, this is a pleomorphic adenoma, which is removed in toto. You don't need to do a formal marginotomy for these patients. What about infiltrative approaches? These are where you just want a tissue diagnosis, but not a needle biopsy, not cells. You want tissue. And that's where examples of patients like these who was referred to us with the superior lid mass, you can see the infiltration along the entire optic nerve. Going and doing a post-bulbar biopsy is going to be dangerous. And you lift the eyelid and you can see this beautiful salmon patch right over there. That's all you need to go for. You don't need to go for the orbital tissue. A simple topical anesthesia, transconjunctival approach to the tissue diagnosis is all that is important to get it as well. So what then is the role for needle biopsies? We still do that. We just did one for a patient of an ameloblastoma, which was excised, a patient from Bahrain who came to us 10 days ago, ameloblastoma of the jaw, excised by a dentist, local recurrence, multiple recurrences, ended up having a more radical excision by a maxillofacial surgeon in Istanbul, then again recurred towards the floor of the orbit, once again excessive resection with the flap and radiotherapy. Now she's got the same ameloblastoma along the skull base, erosion of skull base. All I needed was a tissue diagnosis, stuck a needle in, and we are planning a major reconstruction for excision reconstruction for her. So to me, the indication is a suspected metastasis. And what I like about these kind of cases is it takes 2 minutes to make a tissue diagnosis. Here's an MRI which shows it. Under topical anesthesia, again, transconjunctival approach with a 25 gauge needle. 25 gauge, believe it or not, is a large biopsy. Go in, take out the tissue. It's not an aspiration biopsy. You just need multiple core needle biopsies. Squirt it on a glass slide, put the smear on the slide, and 2 minutes, your cytopathologist says these are epithelial cells with a history of a gastric cancer in the remote past. There's a metastasis to the orbit itself. What about vascular lesions? In the past, we were heroic surgeons, bloody surgeons doing major surgeries itself. But we now know that we classify vascular lesions or vascular malformations into lymphatic malformations, dispensable, which is a venous malformation, and AV malformations, which are quite challenging. Here's a child, believe it or not, treated by a pediatric ophthalmologist, 2 different strabismus surgeries for the compensatory head turn from an exotropia until somebody had the brain wave to go ahead do an imaging. Imaging shows a beautiful lesion, supromedial orbit in a young adolescent girl, and look at the remodeling. Shows it's been there for ages. So this is a classic example of a venolymphatic malformation. So how do we manage it? No incisions at all. Through a needle puncture, get into the lesion, map out the lesion, find out their macrocysts or microcysts with sclerotherapy. You're able to shrink these lesions without any surgical interventions at all. So you don't need to do big surgeries for these procedures anymore. Examples of patients post-operative outcome before and after sclerotherapy, and they require typically 2 or 3 sittings of sclerotherapy. We use STS and bleomycin for these cases. Here's a patient who had multiple extraocular muscle biopsies, and because her large dilated vessels was labeled as a hemangioma of the extraocular muscles. This is nothing but a keratoconus fistula, an AV fistula, which, as you know, is a pathology of the brain manifested in the eye and the orbit. Example of cases where if the transfemoral approach to the CCF is not possible in the hybrid operating theater through a simple cut-down approach, identify the superior ophthalmic vein, we put the catheter all the way into the cavernous sinus and do coiling as well. So last couple of scenarios about orbitocranial tumors and sino-orbital tumors. There's a whole bunch of them nowadays. You now know gliomas, you don't biopsy, you do a combined chemotherapy and radiation. Here's an example of a sphenoidal wing meningioma, a lady who was initially diagnosed as thyroid eye disease for progressive proptosis in a female. Because of TRAB was positive, she was treated as thyroid eye disease for several years before she referred to us. You need a combined cranioorbital approach, excision, and you can do good reconstruction for these patients. Another patient who actually had a progressive proptosis, notice upward shift of the globe itself from a maxillary sinus carcinoma. We talked about a Weber-Ferguson incision this morning. This is a classic example where a combined craniofacial resection can be done, and depending on whether the orbital fat tissue is involved or not, you can do a combined exenteration or no exenteration. You can slap on a flap for these patients and restore these patients. So in summary, I think orbital lesions are widely varied. It's a good combination of preoperative clinical diagnosis followed by appropriate imaging. Then you devise a plan, am I going to do an incisional or excisional biopsy, and so on and so forth, so that you do a total rehabilitation. So you can achieve big things through small incisions. Thank you very much.